Thank you so much for this invite. At the outset, I think the novelty of my presentation has already gone out because of the presentation that was, the panel discussion that was chaired by Dr. Smriti in the morning. So there's nothing new that I'm going to tell you now, but just a recap of things that has already been discussed. So this is the overall survival with CDK inhibitors in advanced breast cancer or metastatic breast cancer. Even though the fact that luminal diseases don't scare us as much as HER2 diseases do, or probably the triple negative and other high-risk categories do, we do know that endocrine therapies are always hanging around just to give us a bite at the time when we are not expecting it. And the most common mechanisms because of which we get into trouble are primarily either the cell survival or the cell cycle pathways that are disturbed or activated, altered, the growth factor signaling pathways that get altered, and the deregulation of the ER pathways. And the basic concept of trying to control these things have come from the idea of trying to bring in drugs which would probably control the mechanisms which would probably give us the endocrine resistance, and that way probably give us a little more extended benefit in these patient subgroups. Now, three different drugs which we've been talking about, both in the adjuvant setting and also in the metastatic setting, palbo-ribo and abemaciclib. I think we have all gotten used to this drug, and we've probably started using it in our, most of us are probably using it in our practices. They are inherently the same class, but they do have some amount of differences between them. Palbo and ribo, being a slightly longer half-life, are generally used up in a daily basis, whereas abemaciclib has a shorter half-life, has to be used twice a day, and that gives us some freedom to use it on a continuous basis, whereas palbo and ribo ends up getting used as a 3-week on, 1-week off sort of a schedule. And there are plenty of trials, all of them listed out here. I'm not going to go into the details of them, which has probably kind of given us the confidence that some of these drugs do have a benefit in our patients, and it adds on to the value that is added to the patient's overall outcomes. Now, the three trials that I'm going to focus on is the Monarch 3, the Paloma 2, and the Mona Lisa 2 trial, but we are going to focus on the overall survival of it. This has already been discussed. Monarch 3 was presented by Dr. Matthew P. Geddes in the ESMO Congress in Paris. Richard Finn presented the overall survival from Paloma data, and overall survival from the ribociclib was from the Hotobaji group, which has already been published in NEJM. And most of us probably have already read through these data. We know that the Monarch 3 study, Paloma, and the Mona Lisa 2 trial, all of them more or less had similar sort of a population group that was being looked at. And you had HR positive, HER2 negative breast cancers, which are postmenopausal, metastatic. In the Monarch 3 and Mona Lisa, there was allowance to use ET in the neoadjuvant setting, but there had to be a 12-month gap between these patients before they were enrolled onto this trial, whereas Paloma 2 trial somehow did not include that particular group. Now, the PFS data has been sitting on our tables for the last 3 to 4 years, and we have all been aware of the fact that all these three drugs do have a good impact on the PFS, and those graphs, like how Senthil was talking about last evening, you can drive a Thar through the gap that you have in these trials and the Kaplan-Meier curves. It is quite impressive, and probably this is what pushed all of us to go ahead and start using our CDK inhibitors in most of our metastatic settings. And probably the decision between some of these have been based on personal comfort and as well as the patient comfort. But we do need to understand that a lot of stuff that has come beyond these initial presentations have been hair picking, or you have got a hair splitting sort of a thing where plenty of exploratory analysis and things that were not planned up front were being discussed, and the conclusions being drawn from there might not have been so prompt and so good to kind of easily just take on. The updated PFS from the Monarch 3 trial again shows a widening. It shows a good 15-month PFS benefit, but somehow none of this really gives us the confidence to go ahead and tell our patients that it is going to really make an impact, because when it comes to younger patients coming to you with metastatic breast disease, the concept of telling them that they're going to improve or they're going to get better is not primarily from PFS. They are going to look at overall survival, and that is something that the patient is going to ask you, how long am I going to live? And if you don't have an answer for that, and it says, no, just it keeps your disease under control for some more time, then the other stuff that I'm giving you, it might not be of so much of value addition, especially when you look at the cost that is involved in keeping these patients parked over a period of time. So it comes down or boils down to overall survival finally. In the interim analysis that we've had the interim analysis of Monarch 3, and the last one was presented in the presentation that was there was from the interim analysis 2, after 80% of the information had been gathered, 5.8 years having been spent, and you realize that around 33, 34 months later, Monarch 3 gives you some bit of divergence of the curve. Whereas in the patients who had visceral disease, again, somewhere close to about 28 months, you seem to have some difference in the curve. So initial 2 years of whatever you've been doing with the drug doesn't seem to make a big impact. If the patient makes through that period of time, probably there's going to be some benefit, but it does not add up to the overall survival in terms of the p-value. They are statistically not significant yet. If you look at all the subgroup analysis, they all check onto the left side of the curve and left side in the forest plot. And that gives you some bit of confidence, but is that valuable enough for you to choose these drugs for your patients? Not really sure. Paloma 2 somehow has been a heartbreaker, and you realize that they don't really make any difference. Mona Lisa, again, had some benefit beyond the 20th month. Paloma 2, we need to recognize that 21% of these patients were censored. They withdrew consent in the actual trial arm, and the post-hoc sensitivity analysis that has been done shows some bit of difference, but again, it is not statistically significant. Again, if you do some hair picking, you would realize the patients who had more than 12 months of DFI seem to have had a better response in the Paloma 2 trial, but that's again a big question mark, because you're really not talking about the drug making an effect. It's more likely that the disease biology on its own probably is doing the trick, and that's not what you're aiming for. Mona Lisa 2, again, if you look at the forest plot, everything seems to favor the ribociclib plus letrozole. Now, one thing that we all heard in the morning is about chemotherapy being used in these patients, but we outrightly heard Dr. Smriti saying chemotherapy is probably not the right choice in patients who are HR positive. Monarch 3 trial, Mona Lisa 2 trial, and Paloma 2 trial, all of them have looked at the time gap that you will get as a chemotherapy-free interval if you choose to use one of these CDK inhibitors. And it seems to have an impact, but I'm not really sure how many of us are going to put these patients on chemotherapy at some point in time if they are strongly ERPR positive. Put all of them together, Paloma 2, Mona Lisa 2, and Monarch 3 trial, you have only the ribociclib group which seems to have made some sort of an impact. The other two have not, and that is something that you have heard. But over a period of time, again, I'm copying Senthil's cartoon, and if we kind of keep digging, you might find a lot of abstract information, and probably that would be used over a period of time to justify the use of CDK inhibitors, especially in the scenario where palbociclib has become so cheap, and we might probably end up starting to use those drugs, but then we'll have to justify it. Problem with the discrepancy is probably with the fact that the primary aim was to look at PFS and not really OS. And the potential reasons for the differences in all these trials is probably the number of patients who have dropped out, and there might be an actual difference between how these drugs really work. So finally, how do we use these drugs? We probably have to look at the toxicity that has been very intensively discussed in the morning. We have to look at how the patient's acceptance is and what is the pill burden that the patient has to take. The wise decision would be you look at the consideration of morbidities and concurrent medications, have a shared decision making, and patients who are already on some form of treatment need not jump onto a new drug just because some new data are emerging. And with that, I'll come to the end of this. Thank you so much.